Hi there. If you're a wound patient reviewing your medical chart and running into terms about your wound that you don't understand, this lecture is for you. If you're a nursing, physical therapy, occupational therapy, or medical student interested in learning the basics of wound care, including the descriptive terms commonly used, you are in the right place. Now, if you are a healthcare professional not directly involved in wound assessment and treatment, remember that the skin assessment or integumentary assessment is everybody's business. So if you have a patient with a wound, it may directly or indirectly impact your plan of care. Therefore, I highly recommend you stay to learn the common jargon used and the common tissues seen in wound assessment. Now, if you're a wound care clinician, you must review. It's time for us to review our basics because the terms that we use or the words that we write have a significant impact on the management and, of course, in patient outcome. We must all be using the correct terms to describe what we see in the wounds because when we are precise and accurate, patient can be assured that they are safe in our hands. So, ladies and gentlemen, buckle up because today I can assure you, as long as you stay, watch, and listen, you will learn practical and useful information in a simplified way. And after watching this video, you will be more knowledgeable in wound care more than ever. So when we are doing wound care assessment, our task is likened to that of an investigator. So there are four places that we need to investigate in a wound. First is the wound base. Second is the wound edges. Third is the peri-wound. And the fourth is the whole person. So this is the wound bed. This is the wound edges. And this is the peri-wound. And we're going to talk about all these three places or four places one by one. So, ladies and gentlemen, we're gonna talk about the two normal tissues that you usually see in the wound bed during your assessment. But before that, let me just tell you, and I'm reminded of what my professor in pathology has told me before that so you can know the abnormal, you should be able to identify first what is the normal. So I think that's also very applicable in wound care because so that you'll be able to know that this is abnormal, you should be able to identify which one is normal. Okay, so what are the two normal tissues that you usually or you should see in the wound base? Because if you see them, you should be happy because you know that the process of closure has begun. But if you don't see them, you should try every means. Your management has to be directed in growing these two important tissues necessary for wound closure. Okay, so what are these? First is the granulation tissue. The second one is the epithelial tissue, and we're going to talk about them one by one. So when we're talking about the wound bed, okay, we're talking about the floor of the wound, or that's what we call the base of the wound. So therefore, wound bed can be used interchangeably with the term wound floor or wound base. There's anything inside these demarcation lines in here. So this is the wound edges right there. And of course, the area immediately surrounding the wound is what we call the peri-wound. So if you see a documentation saying that there is an erythema or there is a redness in the peri-wound, we are talking about this area in here. Or say, for example, you hear the word there's a maceration on the peri-wound, we are talking about this area. This is the area immediately surrounding the wound. So granulation tissue is a new connective tissue and a microscopic new blood vessel. So remember that by definition, granulation tissue is a new connective tissue and a microscopic new blood vessel. So their usual appearance, um, as seen in these pictures, is beefy, red, bumpy, and they are granular, since their name granulation tissue. So why are they red? So let's discuss this further. During the proliferative phase of healing, you know that there are different phases of healing, correct? So the formation of new blood vessel must happen. So there is what we call the process of angiogenesis. Okay, So let's see. That's what we call angiogenesis, which is the formation of new blood vessels. So angiogenesis occurs as new capillary buds from the intact vessels adjacent to the wound extend to the wound base. So like what I said, there is new capillary buds from intact blood vessels. They will now going to extend into the wound bed in here. And then the endothelial cells will proliferate. So the endothelial cells, those are the cells that are responsible in the formation of new blood vessels. So they create new capillaries, and they will connect to form a network of vessels. And this complex now, okay, this is now what we call the granulation tissue. All right. So actually, um, the capillary loops would look like, I should say, as small granules to the naked eye. So it explains, like what I said earlier, it's named granulation tissue. Um, the granulation tissues actually first appear as a pink, like a pale pink buds. As it fills with new blood vessels later, it becomes bright red and appears beefy. Okay. Now the production of granulation tissue is dependent on macrophage accumulation. So macrophages stimulate fibroblast in growth. Then there is a deposition of the loose connective tissue and the formation of new capillaries in the wound. So the granulation tissue formation is also produced by low levels of bacteria. So you need bacteria to stimulate the formation of granulation tissue, but they can be inhibited by high levels of bacteria or high levels of bioburden. Ladies and gentlemen, you should remember that. That's what I want you to remember. You should remember that granulation tissue is found in total thickness or at least stage 3 wounds, not on partial thickness wounds. Because the purpose of the granulation tissue is to fill the gap or the depth or the defect. Okay. Once the gap or the depth or the defect is filled, okay, another tissue now will appear to resurface the wound. So, um, looking at the composition of the granulation tissue, you could explain to your patient that it will never replace the structure of a normal skin. So, question for you is: do you see granulation tissue on stage 2 ulcers or stage 2 pressure injuries? The answer is no. So, when do you see them? You see them on at least full thickness or stage 3 pressure injuries. Okay. Sometimes we run into a situation when you are not sure, we are not sure if the uh, red tissue that we are seeing on the wound base is a granulation tissue or a muscle. So as you can see, by appearance, I want you to remember this appearance in here. These are granulation tissue, and this is how a muscle would look like. So now, to distinguish between the two, um, you could do some palpation. So when you palpate, that's the best way to do, or the best thing to do is to palpate the tissue with your finger. And a granulation tissue usually is soft and spongy, and it will not jump or if pinched. Say for example, if you're going to pinch this with your fingers, it will not jump, it will not twitch, but it may bleed. Why it may be bleed? Because like what I said, it's just a network of new and fragile capillaries or blood vessels. Okay, so if this is a muscle, okay, it is usually firm and resilient to pressure, and it will not jump or twitch when pinched. Okay, so this is the major difference between a granulation tissue with that of a muscle tissue. Just to make sure that you are describing the tissue correctly, so you should be able to distinguish between a granulation tissue from that of a muscle. Okay. So epithelialization or re-epithelialization, which begins a few hours after injury, is another essential feature of healing. Resurfacing of an injured tissue is accomplished by the movement of keratinocytes from free edges, including those surrounding hair follicles and sweat glands at the wound edges. So if you look at this, let me show you the pointer. If you look at this pinkish tissue here, these guys are now ready to migrate in a leapfrog manner towards the center to resurface or close the wound. So the horizontal movement is stopped when cells meet, and it's known as contact inhibition. So it is then crucial that this guy's pathway, the pathway of these guys migrating towards the center, should be free of any debris or necrotic tissue, or else they will not be able to move or migrate completely. So the wound bed is also important to be moist, okay? As these new guys uh, cannot migrate towards the center if the wound base is dry. So honestly, I want to tell you that the typical pinkish appearance described in the literature or textbook may not be seen, but a whitish pink, yeah, whitish pink, more of that one, that appearance there, um, is seen in our naked eye. So, ladies and gentlemen, it is extremely important to protect this tissue from trauma during dressing change or from rough wound cleansing and another form of external uh, trauma, especially friction. Okay, so earlier I mentioned about contact inhibition, and I want you to understand that. So when the epithelial cells from the edges, right, so they migrate towards the center, they move in a leapfrog manner like this. And then when they meet at the middle, okay, they stop their migration, they stop their movement. And that is what we call contact inhibitions. All right, so you learned a new word today, contact inhibition. And by the way, epithelialization or epithelial tissue is seen in both partial thickness or full thickness wound. So if you see a tissue being described in a partial thickness wound and they're using epithelialization or epithelial tissue or also known as epithelium, that is correct. You also see this in in full thickness wound, okay, because like you can see in this picture, once the wound base or the wound bed is filled with the granulation tissue, okay, the next step there in closing this wound, ladies and gentlemen, is to form this epithelial tissue coming from the edges of the wound, from the intact skin, from the edges of the wound, and they're gonna migrate, okay, towards the center, like what I already described, to resurface or to close the wound. It's what we call reepithelialization. So if you are if you work in home health and you see the word reepithelialize, that is what it means. Okay, so meaning to say that if this is a full thickness wound or a stage 3 wound, okay, so the depth or the defect has been filled with a granulation tissue, and the edges has grown this epithelial tissue from the edges, and then they migrated and resurfaced the wound. That's what we call a reepithelialized wound. So, ladies and gentlemen, if you see this documentation that reads, there is an islands of epithelium noted on the lower half of the wound base. What does that mean? Sometimes in during your wound assessment, you see this pinkish tissue at the center of the wounds, and they form like an islands. Okay, so when you see these guys, please do not harm them because they are viable tissues. These are actually islands of, the term for this is islands of epithelium. So um, remember earlier when I was talking about reepithelialization, I was saying that the epithelial cells or the epithelial tissues will be coming from the edges of the wound and they migrate from the periphery towards the center. Sometimes when there is a preservation of the dermal appendages like the hair follicles, the sebaceous gland, and the sweat glands, remember that these are lined with keratinocytes. The keratinocytes, those are the cells that form your epithelial tissue. So in that situation when there's a preservation of these dermal appendages, okay, there will be a way for epithelialization or epithelium or new epitheliums to be arising from the middle of the wound or the center of the wound. And then in this case, you know that reepithelialization here now will be faster because you know why? Because the epithelial cells or epithelial tissues will be coming not only from the edges of the wound, but also coming from anywhere at the center of the wound where the dermal appendages are preserved. So this is one of the mistakes that I've seen when cleansing or cleaning a wound is that you get a gauze and you're just scrubbing all these areas because you see those slough in here. Okay, you make sure that do not harm these guys, ladies and gentlemen. The concept of do no harm applies in this situation. Okay, now you know that there is such thing as island of epithelium. So therefore, when you see these guys, what should you document? in your documentation, in your notes. Okay, you should write there is an island of epithelium noted on the at the center of the wound bed, or the at the middle part, or the lateral part, or the medial part. Okay, wherever. It is important that you need to document this so that the next clinician will be aware, so that during dressing changes, make sure that this are not harmed. Okay. So this is just to show you the dermal appendages that I was talking about earlier. So these are your hair follicles and also your sebaceous glands. So if you can see here, they're all lined up with the keratinocytes. Those are the cells that were formed, the epithelial tissue. Okay, so so this will migrate um, to the surface of the wound at the center if we have a preservation of these structures in this particular wound, and then they will proliferate and help resurface the wound. Okay, so and what you call these guys again, the term is islands of epithelium, and they're coming from a preserved dermal appendages, which are your hair follicles, sebaceous glands. Okay, and always remember, do not harm this tissue when you see them. Preserve them and protect them. So going back to our discussion on granulation tissue, so what if you have this type of wound? So if you see a granulation tissue and they are not enough to fill the defect, okay, like in the case of this wound, what is the term for this? So the term is hypogranular tissue, or a hypogranular wound bed. So is this good or bad? It's bad because epithelial cells, or epithelial cells coming from the edges of the wound cannot dive down to attach themselves to a granulation tissue. Okay, so this wound may not reepithelialize unless the granulation tissue goes up a little bit higher, so that the epithelial tissue will attach themselves to them. Okay, now how about if you have a different type of wound and you see the granulation tissue growing over the edges of the wound, going over the limit of the surface of the wound? So what is the term for this? The term for this, ladies and gentlemen, is a hypergranulation tissue, or a hypergranular wound base. So is this good or bad? It is bad. You know why? Because much as the epithelial cells cannot dive down over a hypogranular wound bed, they cannot also jump over, okay, a hypergranulated wound bed. So resurfacing or reepithelialization will not happen in both situations. So these are the two things that you need to make sure that you're looking at these patterns of granulation tissue. If it's hypogranular, you have to find all means to manage what is causing the sluggish growth of the granulation tissue. Now, if they are hypergranular, or there's a hypergranulation tissue, you need to manage also this granulation tissue. There's a lot of ways to do that. So now, there are causes of the wound base to be hypogranular, or the sluggish growth of a granulation tissue. And and also different reasons why the granulation tissue would overgrow. Okay, and it's beyond the uh, scope of this discussion, or else we're going to be there. This video will be very, very long, but let me just give you a little bit of bird's eye view on what is going on in here. So if you have a hypergranular tissue, which is very notorious, especially after surgery, there are three things that you need to think about. Is there so much moisture? That's number one. Okay, maybe you are not absorbing the exudates adequately. Number two, is there any silent infection? So if there is a high or critical colonization, okay, most of the time or sometimes the wound bed would tend to hypergranulate, and there are also other factors. Okay, so then there are several ways for you to manage a hypergranular tissue. Okay, you can put pressure, you can manage this with silver nitrate, and lately I have tried a very anecdotal way, because I have this patient that has been seen by the dermatologist, and had, the wound wasn't closing because of the hypergranulation tissue keeps growing. It's regardless what we do. They have been managing it with silver nitrate and whatnot, all those um, typical ways to manage hypergranulation tissue has been done, but nothing has had worked. So he came to me. I did the same thing, and it did not work at all. So I was reading the literature, and there were some clinicians that were putting like a topical um, what do you call this hydrocortisone, 1% hydrocortisone on the wound bed every day, and that's what I did. And the granulation tissue has been suppressed significantly, and the wound has reepithelialized. Okay, so from this slide, you learn that there's hypogranulation tissue and hypergranulation tissue. If you see this, you have to note them and describe them as such. And you know that you need it to be managed, or else the wound is not going to close. So let's move further and let's take a look on the wound edges. So if you want to know anything about the wound, just look at the wound edges and it will tell you everything that you want to know. As a wound investigator, okay, by just looking at the wound edges, it will tell you a lot of information about the wound, about how old is the wound, the etiology of the wound, and whether the wound is gonna close soon, or the wound is stalling and whatnot. Okay, so in this picture in here, the first picture that you see, okay, so you can describe this as either attached, okay, or not attached. Okay, so you know, ladies and gentlemen, that an attached wound edge would close, right? If the wound edge is not attached, it will not close. Other way to describe this too is that attached and not advancing, or attached and advancing. If you see some movement of the epithelial cells or epithelial tissue moving forward here, and then you can describe this as attached and advancing. Okay, and this wound that you see on the second picture is, if you look at the, this edge here, ladies and gentlemen, it's curled inward. Okay, so this is what we call epithelium. Okay, so when you see this type of wound edge, okay, you have to describe this as epithelium. So this is curling in of the tissue. You know why? Because look at the wound bed. It's hypogranular, like what we said earlier. So the edges were waiting and waiting for so long, okay, and then they're ready to migrate and move forward, and they were looking for a place to attach, and they couldn't attach because this is so deep. Okay, so what they did is that instead of moving forward, okay, they went down like this, and since there's no place to attach in this area, they curled in and looked for another place. Okay, so instead of going forward, they went like this. Okay, and then once this epithelial edge will reach the another epithelial surface in here, okay, they will go into what we call the contact inhibition that we described earlier. Okay, so now when there is a contact inhibition, that would send a signal to the brain that, or to the body, that the wound is already closed, and it will bring about the chronicity of the wound. Okay, a lot of the wounds that referred to our service, when we take a look on the wound edges, when I see this epithelium that has not been managed, I was telling myself, what were they waiting for? Okay, because once the edges curled like that and go into epithelium, okay, that sends a signal to the body that the wound is closed. It's no longer the priority of the body. And sometimes if you see a wound base like this, you would it's not surprising that you don't see a lot of inflammatory response at the periwound when you see an epithelium. Okay, you know why? Because like what I said, it's no longer the priority of the body. The body has forgotten about this wound because of the contact inhibition. The body thought that this one is already closed. Okay, and the other way for you to for these edges to curl in is that even if, okay, even if assuming that the wound base is granular and they were able to attach themselves to the granulation tissue, if the wound base here is so dry, okay, the epithelial tissues, the epithelial cells cannot migrate over a dry wound base. So they're gonna look for a moist environment. So and it's usually it's the inside environment that's moist than the outside environment. Okay, so this is the reason why they follow that moist environment until they meet another epithelial cells inside, and then they go, hello, Okay. They greet each other, and then they can stop migration, and and like what I said earlier, the body would think that the wound is already closed. So this needs to be managed. Okay, the other type of wound edge that you see, ladies and gentlemen, it's whether the wound is undermined or there's tunneling. So you know that this um, cannot reepithelialize because of the presence of this gap. And if you go further, if you see a spacer with is multi-directional, that is, we have to describe that as undermining. Okay, so when it's unidirectional, we call it tunneling. Okay, so there's a difference between the two, and I have a separate video about that too. So just look at on my channel. I made a video differentiating between a tunnel and an undermining. All right, so how about if you see this type of wound and it comes with these irregular borders, and you cannot really define it, like with a circular or whatnot, it's broken, you know, and whatnot. So we call this irregular border, or what we call undefined border. Okay, so naming wise, you can call this as attached or not attached, attached, advancing, or attached, not advancing. You can call this as a curled or epithelium, okay? And then you can also call this either undermining or tunneling. You will never, you wouldn't know until you do a thorough assessment to see if it's multi-directional and it's undermining, and if it's unidirectional, it's tunneling. Remember, ladies and gentlemen, that a tunnel would usually uh, cause abscess formation. It's associated with abscess formation. So you have to make sure that you manage the tunnel. Okay, this one is the edges of this one is called irregular or undefined border. Earlier, I was telling you that if you look at the edges of the wound, it will tell you a lot of information. So if you see a wound edge which is perfectly round or oval like this is usually seen on arterial ulcers if you're looking at a wound in the lower extremity. So if you see a irregular border like this, let's see, if you see an irregular border like this, okay, and this is in the lower extremity, it's usually associated with a venous ulcer. Okay, I was saying earlier, I didn't have the cursor, so this one is more of a regular, perfect oval or perfect circular. It's usually associated with arterial ulcers, especially if they are found on the lateral aspect of the extremity. Venous ulcer, by the way, is usually found on the medial aspect of the extremity. Anyway, so let's talk about the peri-wound. So in this first slide that you see, you would describe this as intact, or you have to say there is no erythema. Why is it important for you to say there is no erythema? You in documenting what you see in the wound, ladies and gentlemen, you are not only documenting what you see, but you're also documenting what you don't see, because those things that you don't see and you documented them, it will save you a lot from litigations in the future. Okay, so like say for example in the court of law, if you have a case and the wound got infected and you're gonna get sued, blah blah blah, blah, and then during your last visit, it is important that you are saying things that pointing to the idea that there was no infection. There is no sign of infection when you last saw the patient. So it's important that in this wound, I would describe this. I would describe the peri wound as intact, and I would say there is no erythema. Okay. So the other picture here is that if you look at the redness, the erythema around the wound, so see how I want you to appreciate how consistent the erythema is with the contour or the shape of the wound. So if you see this one, you look at the wound base. Why is this happening? Okay, so look at the wound base. So in the presence of an eschar or a necrotic tissue like this, the body will not like this. The body will do everything to get rid of this one because it's recognized as a huge foreign body. So therefore, it triggers an inflammatory response and it will manifest as redness. And usually, it is consistent to the contour or the shape of the wound. However, it is different when you see this erythema and it's going away like this, like in this type of a surgical wound that you see in this picture. Okay, look at the erythema. It's not consistent. It's like it's going all over the place. Okay, it's like a butterfly. So that means to say that this is that is not the normal inflammatory response. The body is fighting against invader in here. So I would label this as concerning for infection. Okay. However, when you say infection, be careful when you're using the word infection. You have to look at other triggers, okay, or other signs and symptoms that goes along with this presentation. Okay, so if this surgical wound has drainage and the patient is not feeling well, there's increased pain, and the patient just tell you, I'm not ranging my knee the way I was ranging like 2 days ago or a day ago, or something like that. It's really, really difficult for me to move, and there's excruciating pain, and you see this redness in here. That would be a big uh, red mark for you to consider infection in these situations. Now, if you see the whole or in the entire periwound, right? It's like this whole area here is all red. So if and it's extending to the whole extremity or a significant portion of the extremity, this is usually found in patient with cellulitis. So looking at this picture, to see all those hyperkeratosis here, this is usually found in patients with chronic edema, like in the case of patients with lymphedema. So you know that in patients with lymphedema, cellulitis is always a problem with them. Okay, because they lost the surveillance function, the immune function of the lymphatic system in lymphedema. That is the reason why they're always vulnerable to having cellulitis. And the redness is usually massive. Okay, like what I said earlier, when you see this one, you should also look for other signs like swelling, increasing swelling, warmth, tenderness, etc. And the patient's not feeling well. Okay, you should highly consider cellulitis in this situation.
Thank you for being here. I will see you on the second portion of this video. See you there.